Apothecary Podcast. Authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacists Jamie, Gimmo and STC take on topical and controversial stories but keep it edgy yet light-hearted.
Pod guests share their desert island drugs and joyful patient stories.
Welcome, this is the Oral Apothecary Podcast. My name is Jamie Hayes. Coming up in this week's episode, we're joined by Dr. Tessa Lewis. Tessa is a general practitioner and medical advisor. We'll hear from Tessa in a moment as she shares her desert island drug, a career anthem, and recommends a book for the Oral Apothecary Library. Our micro-discussion will look at potentially inappropriate prescribing in people with chronic kidney disease. But first, let me welcome my two fellow apothecaries. STC is in Bournemouth and Gimmo is in Cardiff. Welcome both.
Evening both. Oh, I've been busy this week, I must say.
What have you been up to?
You're a practicing clinician, Steve?
I am, but we got back to teaching, which has been lovely. We've been teaching GPs and clinical pharmacists about learning sets around polypharmacy and deprescribing with Wessex AHSN, with Claire Howard and Zoe.
Face-to-face?
No, on Zoom, which is not quite the same, but it does have some benefits, I suppose. I can't reveal anything because otherwise I'd have to kill you, but I've also been doing some legal work as a clinician expert, so that has been taxing me. My word, barristers, they are very clever minds.
You make sure you pay your tax as well.
We can tell when Steve's busy because the volume of stuff on the WhatsApp group drops down.
Yeah, you're right. Although I wouldn't want to disappoint the listener by saying I haven't listened to any podcasts this week. And Paul did mention on the WhatsApp group this week, Steve, do you listen to podcasts in your sleep? Because I had listened to so many. I am a machine. But I must just give a shout out to Cautionary Tales, which is by one of my favourites, Tim Harford. And he talks beautifully about masterly inactivity is the episode that I listened to. And it was actually Jonathan Underhill, last week's guest, who put me onto it. It's brilliant.
The week before's guest. Gimmo?
Not much really, just busy. One of my lockdown purchases, which seemed like a good idea at the time, was a stand-up paddleboard, so I took that out on Sunday, which was a complete disaster. I've invented a new sport, sit-down paddleboarding, because I was just too wonky. But that was fun. If you live in Wales and you work for the NHS, if you check your pay slip today, you'll have had a nice surprise.
Oh?
We got our 500 quid COVID bonus today.
No way.
So, yeah, everyone in Wales who works in NHS got 500 quid. Well, I think it was everyone. Got £500 today.
Whoa, wind back there. I've not heard this. This is big news.
It's in Wales, and I think they did it in Scotland a couple of months ago, and they've done it in Wales.
Healthcare is a devolved function.
Yeah. Thank you, Welsh Government.
I'm not worthy down here.
Okay, while we're on thank yous, thank you to everyone who is listening. Through your support, you have taken us to number 15 in the Apple Medical Podcast charts. We did get into the top 10 in Series 1, and so we're looking to improve on that with this second series. So please share the details with your colleagues, friends, and family. And also, one other thing from me, there seems to be some confusion out there. Following last week's outing that I used to listen to Richard Clayderman, I just need to clarify that I would do my study and revision whilst listening to Richard Clayderman, and I would get ready for exams and other big events to Guns N' Roses. And so my career anthem, which you will find on our Spotify playlist, is listed as Sweet Child of Mine. I hope that clears things up. Okay, my great pleasure to welcome Dr. Tessa Lewis to the Oral Apothecary Podcast. Tessa is a GP in Blaenavon. Again, for our international audience, Blaenavon is designated as a World Heritage Site and is nestled between the Brecon Beacons and the South Wales Valleys. Sounds lovely, doesn't it? Tessa has split most of her career between being a GP and as a therapeutics and medical advisor for organisations such as the All Wales Therapeutics and Toxicology Centre, the National Institute for Health and Care Excellence, and more recently, Public Health England. Areas of particular interest include antimicrobial stewardship, anticoagulation, multimorbidity, and medication review. In 2004, Tessa published the No Tears approach to medication review in the British Medical Journal, and in 2019, she was one of only 20 individuals who received the Distinguished Contribution to NICE Award, recognised for having made an outstanding contribution to NICE since it was established in 1999. It's a list of very impressive people, and having known Tessa for the last 20 years is so well deserved. Hi Tessa, welcome to the Oral Apothecary.
Well, thanks Jamie. It's a real pleasure to be here. I really enjoy listening to your podcast. It makes me smile on the way to work and on the way back. Thank you.
That's what we're after. What's on the agenda at the moment, Tessa, that you can share with us?
Well, GP-wise, I think lots of GPs, we're sort of reviewing how to restructure our appointment system. I think it's a real challenge. It's a really crucial moment for general practice. How do we keep the good bits from what we've learned over the last year, but retain the essence of general practice? I think one of the things I think would be great if we could improve on is continuity care. So over the last 10 years, we've probably been emphasising access, and you see that the continuity of care is really it's harder to achieve. I think you had Karen last week talking about relationship-based care, and it's so important. And I think without that, you're going to use, more medicines, do more tests. So the RCGP have highlighted it as a key thing to focus on, and I think it can't come soon enough, really. That's the GP side. Shall I go on to a bit of therapeutics?
Yeah, please do.
On the therapeutic side, what has been driving me is a safe and effective use of medicines and a sustainable NHS. One of the challenges as a GP is trying to keep up with this huge volume of evidence. And so working with the common infections team, we've tried to identify some of the key messages for prescribers, what's new, what's changed, and develop resources for a really rapid update, something you can do. So like we did a sinusitis quiz slide set you could do in 15, 20 minutes with your practice team. So I've done quite a lot of work along those lines on urinary tract infection, so quiz slide set, and just about to publish, that's now been turned into an e-learning for health module on UTI, with Public Health England working on similar stuff for skin infections, which have just all been published. Been enjoying that.
Sounds good, thank you. STC?
So Tessa, it's a real pleasure to meet you, virtually obviously, but your original No Tears tool back in 2004, wasn't it, is still used. We teach, and we used it this very week, and we talked to people about it. And the reason why I think GPs love it is in relation to the simplicity of it, denigrating the simplicity of it, but it's the simplicity of it that really works. My question really is, you're talking about continuity, so you're obviously a big advocate of the need for medication review in the same way that you're saying that continuity is important because otherwise it's more difficult. So just how much harder do you think it has been to do good medication review with perhaps a moving away of continuity since 2004, which I think is what you're saying?
Yes, I think when you're doing your medication review, you want to make really good records because, it can be really daunting, can't it? Sometimes you've got this massive list of medicines to look at. But if you've done a good one and you've documented it well, the one that your review the next year should be so much easier. And you've spent that 10 minutes, you've had a chance to, if you're lucky, a bit longer, really get to the crux of what matters to that person, making sure that everything's up to date. Sorry, I'm at risk of taking you through the No Tears.
No, absolutely. I suppose it's the what matters to patient didn't feature explicitly, did it, in the No Tears? But other than that, it still pretty much does the job, as a simplicity way of almost like the medical thinking in relation to acronyms to help you remember stuff.
Yes. So you've got that very beginning bit, which is need and open questions, where you can start using that. But yes, the nice multi-morbidity guidance that came out much more recently has been great in trying to remind people to ask about people's values and goals.
So we're underselling it here, I think. Let's go back to 2003, 2004. You're a jobbing GP in Blaenavon, and you publish No Tears in the BMJ, which is a great achievement in itself. If you Google No Tears medication review today, it has hundreds and thousands, millions of hits around. They're all over the world in how people are still using it and referencing it. And that's what we crave for, isn't it? That simplicity, that memorability for so many of these tools and implementation techniques.
Yeah, I thank you for that. To be honest, I had no idea, but
you're stuck in Blaenavon, you don't know what's on the other side of the world.
You Google it every week, I'm sure.
No. But no, I really want to say that it was based on, what triggered it was the National Prescribing Centre work, Room for Review.
Not the Bond movie.
and the NPC cascades, which was so important at that time. And they did provide a great opportunity for GPs who were interested in therapeutics to get rapid updates. And that was, really important.
It just reminded me of the Room for Review. That was the stuff that brought in level 1, 2 and 3 medication reviews, wasn't it? That was fantastic stuff. That's probably still relevant today. I did try and find that once recently, and it's really difficult to find on Google.
It's impossible to find anything that's been archived in
to
do with Department of Health.
Look, Tess, you just mentioned the NPC, and when we had Jonathan on on episode 1 of series 2, we didn't really get a chance to, discuss that with him, because that was a massive success, wasn't it? The cascade that himself, Jonathan Underhill, Neil Mascray, Martin Durden, Tom Wally, that they instigated, and that training network. We don't have quite anything like that at the moment. I know you're interested in developing therapeutic leads networks. How is that going?
Well, when I've spoken to GPs, a lot of us will go back to the NPC cascades and how effective that was. And having people who are interested and you can bounce ideas, so useful. And I really missed that during COVID, actually. There was a few issues that came up very early on that you needed to be able to get other people's views. You speak to one GP or a couple of GPs, they never have the same view, do they? Or the same experience. So that was a real challenge. So we've taken a paper through All Wales Medicine Strategy Group to try and propose a GP network. There's some other early talks going on elsewhere. It's been very slow. The doors seem to be opening slowly.
So, Tessa, in England, you might be aware of this, but just the very latest edition of structured medication reviews through the contract, which is supposed to be done by these clinical pharmacists who are funded centrally, it's been said that you can expect it to probably take half an hour. What's your view on that?
I mean, that's fantastic if you can. I mean, I do think GPs do to get through a lot of stuff in 10 minutes, but at the moment, I've seen the complexity of healthcare just increasing over the years, and it is a real challenge. There's a balance, isn't there? I would love to see longer consultations so that you can really get to the crux of what matters and have a proper risk-benefit discussion with people.
Do you remember, Jamie, when we did that experiment where we gave GPs half an hour to do a medication review? It was a nightmare because they sort of did everything in 10 minutes and then didn't know what to do with the other 20.
Had a cup of coffee.
You've got half hour. Take your time. Address the patient's needs. Go holistic. Straight through the routine in 10 minutes. Next.
A slight change of tack. You mentioned briefly in that intro stuff around UTIs, and I remember there was a piece of work I was involved with, a pharmacist down here called Avril Tucker, and she created this module, UTI Friday, and I think you worked with that, didn't you, and developed it into something that was in the GP contract. And again, that plays to this idea of how you do things around simplicity, because that was basically an audit looking at antimicrobial prophylaxis in UTIs. But it's simple, but what it pulled out was fantastic, because obviously there's massive overprescribing in this area. It's a really big area in terms of antimicrobial resistance, and again, it was a simple audit that raised awareness and gave you the tools to do something about it.
That was brilliant. The work that Avril and the antimicrobial pharmacist did was brilliant. It came to me as a jobbing GP. My concern always is that in the front line, you're not aware of the latest evidence. But this came to me as an audit pack. The antimicrobial pharmacist had gone through my patients on urinary prophylaxis, given me a lovely set of different groups of patients of priority that needed action with a slide set that I could do with our team. It was, that's the way to really make change, I think. It was very impressive.
Dr. Lawrence Brad, who you may have heard on our previous series, is very big on that, and this idea. And when we do our polypharmacy deprescribing, part of it when you come on it, 'cause it's quite intensive, but part of it is you go back with a pack of slides, as you've just described, to go back to your practice, because you've all got lots of different types of prescribers now in a general practice, haven't you? Not just GPs, you've got nurses, paramedics, pharmacists, physios. So that's exactly the way that we design it. Because I know, having worked in practice, how time is of the essence, and therefore you've got to make it simple, which takes us back to your no tears model and why it's been so successful.
So Tessa, the no tears model, published in 2004, who was your first rapid response on the BMJ site? Do you remember?
The first rapid response, I think, said there's no way you can do this in 10 minutes. That's the only one I think I've seen. Is that right?
Well, I don't know. I didn't actually read her content, but I'll remind you who it was. It was Lely Obo, at the time Senior Prescribing Advisor at Lambeth PCT. And so we'll be welcoming Lely onto the pod in a few episodes' time.
It's not just thrown together.
Steve is going to tell the listeners how this is put together.
Right on cue.
Very good. And, I made the mistake of answering the phone to Avril once, and the next day I was in a school teaching 5-year-olds the e-bug programme. Stunning. It was brilliant. Didn't seem brilliant at the time.
Don't make it simple, make it simpler. That's what a physician once said to me.
The Oral Apothecary is sponsored by Jamie Hayes Executive Coaching and OneLessPill.com.
Okay, so Tessa, great to have you on, and I'm sure you've given much thought to the features that we've brought to the Oral Apothecary podcast. You know the drill. What would you like to offer us as your desert island drug?
Okay, I'm going to go for benjoflumethiazide.
Ooh, the longest one.
That's sort of based on two really strong early memories. So very early on working on the wards, I was just aware how many people were coming in with medicines-related admissions, particularly diuretics. The other strong memory was I don't know if you know the Cardiff St David's Hospital, centre of Cardiff, old Victoria building. And that was one of my very first jobs. So I was sort of rattling around this partly deserted hospital that was about to close, on a house officer for a post-op hip fracture ward. I really wasn't quite sure what my role should be there, how much I was meant to investigate why people had fallen. Some had been investigated, some hadn't. So those were really powerful memories. And working on guidelines, I was worried that they just don't reach people in the front line. But hip fractures is an area of care that we've seen absolutely transformed. So we've talked about the medication review side of things that I got interested in the early 2000s. And the first piece of work I did with NICE was 2011, the hip fracture quality standard, and managed to have a bit of a say there about